Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr.Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Rajahmundry, Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. My email is sreeklpm@gmail.com. Today we are going to talk about one of the most challenging and fascinating topics of neuro-ophthalmology, the counter role, the ocular tilt reaction and skew deviation, cranial nerves part 39, ocular motor nerves part 25. So first we need to talk about counter role to understand the ocular tilt reaction and skew deviation. These are the most challenging and fascinating topics of neuro-ophthalmology. So first of all, the counter role. The counter role is a physiological mechanism. It is not pathological, it is physiological. But what exactly is counter role? To understand that, we first try to understand the oculocephalic reflex. Imagine there's an object in front of me, a pen. When I look at the object pen, it goes onto my macula and the image is very sharp. So the primary objective of ocular movement is to keep the image sharp by focusing it onto the macula. So when I keep the object in front of me and I look at it, the image falls on the macula, it is sharp and clear. But when I turn my head to the left, the eyes also should not move along with my head to the left. The eyes should move to the opposite side so that the image still falls on the macula and the image is sharp. So this is known as oculocephalic reflex, the horizontal movement of the eyes in the direction opposite to the head movement. So oculocephalic reflex is a horizontal movement, whereas the counter role is a tilting movement. So in oculocephalic reflex, horizontal turning the head to one side causes deviation of the eyes to the opposite side, so the image falls exactly on the fovea to get a sharp and clear image. So this is when you turn the head horizontally. But now let's see what happens when we turn the head in a tilting manner to one side. So when I tilt my head to one side, but still I need to look at the image. When I look at the image with head straight on, the image falls on the fovea, so it is clear. But when I tilt my head to one side like this, the eye on the side of the rotation should go up, intort. The other eye should come down and extort, so that the image still falls exactly on the fovea and becomes sharp. So when I tilt the head to one side, the eyes also should go to the opposite side in a tilted manner, as exactly for the countercephalic reflex. This is known as the counter role. So when the head goes in one side horizontally, eyes go into the opposite side, it is oculocephalic reflex. But when the head tilts to one side and eyes get tilted and go to the opposite side, this is known as the counter role, so as to get the image exactly on the fovea and to maintain it in a sharp manner. So likewise, when the head is tilted to one side, example the right side, the eyes are tilted to the opposite side, causing the right eye to raise upwards and intort, that is superior rectus and superior oblique, and the left eye to depress downwards and extort, that is inferior rectus and inferior oblique, known as the counter role. Counter role is physiological, but when there is a lesion, it produces pathological changes known as ocular tilt reaction. So ocular tilt reaction is just the opposite of counter role. So here when I turn the head to one side, the eyes are also tilted to the same side. So this is ocular tilt reaction. However, in lesions of the peripheral vestibular disease, that is the otolith pathway including the medullary and thalamic lesion, the counter role is affected and results in ocular tilt reaction, the opposite of counter role. So when I turn the head to one side, the eye should turn to the opposite side, that is the counter role. But when it becomes pathological, when I turn the head to one side, the eyes are also tilted to the same side, that is known as ocular tilt reaction. So ocular tilt reaction consists of head tilt, skew deviation and ocular torsion. So ocular tilt reaction, as you can see in the diagram, it contains head tilt, skew deviation and ocular torsion. Right, to understand this counter role and ocular tilt reaction better, we need to understand this diagram, which is so simple but gives a wealth of information. So with this diagram, we can place the lesion whether it is in the medulla or thalamus. If there is a medullary lesion, the eye will be looking downwards on the side of lesion. If it is a thalamic lesion, the eye is raised upwards on the side of the lesion. So to understand this, we need to understand this simplified but self-explanatory and wonderful diagram. So here, if you can see, you have this otolith, the utricle, the otolith apparatus. So it comes, the vestibular apparatus, utricle, this is known as otolith pathway. It comes from the vestibular apparatus, comes like this and crosses over to the opposite side at the level of the pons and ascends in the MLF, medial longitudinal fasciculus, connecting fourth nerve nucleus as well as the third nerve nucleus. Third nerve nucleus has got important muscles to regulate vertical eye movements, that is superior rectus, inferior rectus and inferior oblique. The fourth nerve nucleus has got an important muscle, superior oblique, to regulate the vertical eye movements. So when the otolith pathways are connected to the third nerve nucleus on the opposite side, it gives rise to the superior rectus. It goes and supplies to the superior rectus. But we all know, we have studied it, that the superior rectus gets the supply from the opposite third nerve nucleus. So the third nerve nucleus again supplies the superior rectus back to the side where the otolith pathways originated. And then the other two muscles, the inferior rectus and inferior oblique, go to the same side. Likewise, the fourth nerve nucleus supplies superior oblique on the opposite side. So finally, the superior rectus and the superior oblique are supplied from the same side as the otolith apparatus or the otolith pathways originated. So this is a very simplified diagram explaining the challenging topic of counter role and ocular tilt reaction. So the otolith pathways from the vestibular apparatus crosses to the opposite side, supplies the fourth nerve nucleus, which supplies the superior oblique on the opposite side. It goes and supplies again the third nerve nucleus, which supplies the superior rectus on the opposite side, and inferior rectus and inferior oblique on the same side. So when the vestibular apparatus on one side, for example, this side is stimulated, the right side is stimulated, the right superior rectus and the right superior oblique on the same side are stimulated because of the double crossing over, and the inferior rectus and the inferior oblique on the opposite side are stimulated. So when we stimulate the vestibular apparatus by giving a roll, by tilting the superior rectus, superior oblique on the same side, the inferior rectus and inferior oblique on the opposite sides are stimulated. So the eye raises, intorts, the eye descends and extorts. Such a simplified and fascinating diagram. So when the vestibular apparatus is stimulated on one side, example the right side in this diagram, the right side superior rectus and superior oblique are stimulated. So eyes goes up and intort, whereas on the left side inferior rectus and inferior oblique are stimulated, so eyes descend downwards and extorts. This is counter role. Now let's see what happens if there's a pathology. So the pathology can occur here, that is in the medulla oblongata in the same pathway, or higher up in the thalamus. So the lesion can be either in the medulla oblongata where it has still not crossed, or in the thalamus where it has already crossed. So what happens? So when the vestibular apparatus on the same side is stimulated, the otolith pathway, the superior rectus and the superior oblique on the same side are stimulated, so the eyes go upward and intowards. So when there is a lesion in this pathway, the eye cannot go upwards and intowards, the eye comes downwards. So in a medulla oblongata lesion, when there is a skew deviation, the eye is on the lower side as that of the lesion. So when there is a lesion in the medulla oblongata, instead of eye going up and intorsion because of superior rectus and superior oblique, it comes down, and therefore the eye which is on the lower side is on the side of the lesion in medulla oblongata when there is skew deviation. Now let's see what happens if there is a thalamic lesion. When there is a thalamic lesion, but before there is a lesion, what happens? Let's see. Here what happens, the inferior rectus and inferior oblique are stimulated, so eyes are looking downwards. This is physiological. So when there is a lesion here in the thalamus, the eyes, instead of coming down because of the inferior rectus and inferior oblique, it goes upwards. So in a thalamic lesion, when there is a skew deviation, the eye looks upwards on the side of the lesion. So very fascinating concepts, challenging concepts can be well understood with this simple diagram. So normally when the vestibular apparatus is stimulated, the eyes are on the upper side, and on the opposite side the eyes are on the lower side. But when there is a lesion, the eye comes down on the side of the lesion, and here the eye goes up. So in a medulla lesion and thalamic lesion, there is skew deviation, but in medullary lesion the eye looks downwards on the side of the lesion, whereas in the thalamic lesion the eye look upwards on the side of the lesion. So such wonderful concepts can be explained with this simple diagram. Yeah. So counter role is when we turn the head to one side, the eye goes upwards on the same side, superior rectus, superior oblique intowards. The other side eyes comes down, inferior rectus and inferior oblique, and extowards. This is physiological, ocular or counter role. But when it becomes pathological, opposite things occur, what you call as ocular tilt reaction. In ocular tilt reaction, it consists of skew deviation. Skew deviation is a vertical misalignment of eyes. So in ocular tilt reaction consists of skew deviation with the torsion of the eyes and head tilt. The head and the upper poles of both eyes tilt towards a hypotrophic eye. So in a counter role, when I tilt to one side, eye goes upwards and the other eye comes downwards. It looks on the opposite side. Ocular tilt reaction is a lesion. So the head, when it is tilted to one side, both the eye looks towards the side of the tilted head. So ocular tilt reaction consists of skew deviation with torsion of the eyes and head tilt. The head and the upper pole of both eyes tilt towards the hypotropic eye. It occurs primarily with peripheral vestibular disease and can be seen in lateral medullary infarction. So ocular tilt reaction, as we have already discussed, the pathways responsible for the ocular tilt reaction crosses the midbrain, crosses the midline just above the sixth nerve nucleus and ascends in the contralateral MLF. Lesions in the lower pons, that is in the medulla oblongata, Wallenberg syndrome causes an ipsilateral OTR wherein the eye is hypotropic. The eye turns down on the side of the lesion, whereas more rostral lesions like thalamic causes a contralateral OTR wherein the eye is hypertropic. The eye turns up on the side of the lesion. Cerebellar lesion may cause either an ipsilateral or contralateral OTR depending on the structures involved. So the pathway is responsible for the OTR crosses the midline just above the sixth nerve nucleus and ascends in the contralateral MLF. Skew deviation. Skew deviation is a vertical misalignment of the eyes, as we have just discussed, because of the otolith pathways. Skew deviation is a vertical misalignment of the eyes that usually results from a prenuclear lesion involving the brainstem, that is the medulla oblongata or cerebellum. The deviation is usually committant, remaining about the same in all directions of the gaze, and the lesion is usually on the side of hypotropic eye if it is medulla oblongata lesion. Skew deviation is sometimes associated with an INO with the lesion on the hypertropic eye, that is usually thalamic lesions. Another important sign which can be understood by this ocular otolith pathway is the Bielschowsky head tilt sign. So as we have just discussed, when the head is turned to one side, when the head is tilted to one side, the eyes are tilted to the opposite side. This is known as counter roll. So in patients with fourth nerve palsy, that is the superior oblique nerve involvement, may tilt the head to the opposite side to eliminate diplopia, so that the affected eye may go into extorsion out of the action of the weak superior oblique. Imagine a person has got superior oblique weakness on this side. So when there is a superior oblique weakness, there is a diplopia, and the diplopia worsens when I put this weak muscle into action, that is intorsion. So in order to reduce diplopia, I should move the superior oblique out of its action. That means I should put the superior oblique not into intorsion, but I want to put it that side into extorsion. So how can I do that? Imagine I have this right superior oblique weakness. That means there is problem with the intorsion. So when I use my right superior oblique, the vertical diplopia worsens because I am using my superior oblique. So when I turn the head to the opposite side, the counter roll comes into effect. So the eye on this side, it goes up, superior rectus and superior oblique. This eye, the affected eye, it comes down, inferior rectus and inferior oblique. Now it goes into extorsion. So I am removing the action of the weak superior oblique of, that is intorsion, and trying to activate inferior oblique and cause an extorsion movement, so that I am putting the weak superior oblique to rest, so as to decrease diplopia. Diplopia worsens when we use the weak muscle. So superior oblique, when there is weakness, there is worsening of the diplopia when we use the superior oblique muscle. So in order to eliminate diplopia, we should give rest to superior oblique and activate the inferior oblique of the same eye. So Bielschowsky's head tilt sign, patients with fourth nerve palsy may tilt the head to the opposite side to eliminate diplopia, so that the affected eye may go into extorsion out of the field of action of the weak superior oblique. If diplopia improves with the head tilt to the left and worsens with the head tilt to the right, the patient has a right fourth nerve palsy. Forcing the involved eye to intort worsens the diplopia. The ocular tilt reaction can stimulate the fourth nerve palsy, because both cause an unusual head tilt. So how do we differentiate the ocular tilt reaction and the fourth nerve palsy, which look alike? The differentiating point is that ocular tilt reaction causes skew deviation due to asymmetry in the otolith pathway from the utricle, and therefore it improves with assuming supine position due to gravity elimination, whereas fourth nerve palsy persists irrespective of positional changes. Fourth nerve palsy is a palsy, so irrespective of positional changes, the deficit continues to remain, whereas ocular tilt reaction, skew deviation, is because of the asymmetry in the otolith pathway from the utricle, and therefore it changes with head position and improves with assuming supine position due to gravity elimination. Whereas fourth nerve palsy persists irrespective of positional changes. So these are all the complicated, challenging and fascinating topics of counter roll, ocular tilt reaction, skew deviation and Bielschowsky sign. Such complicated and challenging topics can be understood with a simple diagram which I have shown. So when we see this diagram and understand it, such complicated matter can be easily understood and such challenging topic can be understood easily, appreciated, and then we really get fascinated by understanding these challenging topics. I hope you have really enjoyed listening to this video. The other important concepts of neuro-ophthalmology, I have put it in not only neuro-ophthalmology, entire neurology, I put it into a question answer format in a book called Focus Neurology, written by me, Sreenivas, which is available from all leading booksellers online, including Amazon. So if interested, it could be bought online from Amazon. If you have really enjoyed this video, which I have really enjoyed, please like, share and subscribe to my YouTube channel, Dr. Sreenivas Medical Concepts, and my webpage, Dr. Sreenivas Concepts. Thank you. Bye.